Medicina veterinaria es sobre diagnóstico, completo y precoz. Con IDEXX, su clínica puede realizar un chequeo 360 en pocos minutos. Con IDEXX tienes prueba rápida y SNAP, hemograma en ProCyte One, un perfil bioquímico amplio, incluyendo el SDMA en el Catalyst One. Y ahora concluimos el análisis de orina con el UA y con nuestro nuevo SediVue DX. ¿Y sabes qué es aún mejor? Todos esos resultados estarán listos en menos de 15 minutos. ¿Ves qué rápido es obtener el diagnóstico 360 de tu paciente aún durante la consulta? Ahora con los resultados en mano, listo para que cierres el diagnóstico de tu paciente, sin complicaciones, eficiente y en el momento que lo necesitas.
Hello, thank you for joining us to hear more about feline pancreatitis. I'm Dr. Celeste Clements, a board-certified veterinary internist representing IDEXX's Global Medical Education team. I've trained at the University of Florida, New York's Animal Medical Center, and Texas A&M University, and practiced internal medicine in Maryland and Texas before joining IDEXX. For cats that are very ill or those that aren't doing right, the ADR cat, feline pancreatitis is an important differential diagnosis. Today's presentation is entitled Feline Pancreatitis, Diagnosis, Treatment, and Outcomes. Are we getting any better? After viewing this presentation, I hope that you will become more familiar with pancreatic physiology and pathophysiology, that you'll recognize the clinical picture and when to suspect pancreatitis and understand how to diagnose the condition. As well, I hope that you will be able to recall potential complications of pancreatitis and common concurrent diseases, and then formulate individual patient treatment plans and follow-up based upon an evolving problem list. I'd like to introduce you to George, whose story is based on actual patient results modified for this educational presentation. George is a 7-year-old neutered male Abyssinian who presented for progressive lethargy, hyperexia, and weight loss for 7 days. His owner had noted occasional vomiting and diarrhea over the previous 6 months. More recently, however, he'd been sitting sometimes with his rump in the air and seeming a little bit uncomfortable. On physical examination, he had normal vital signs, was quiet and slightly dehydrated based on poor skin turgor and tacky mucous membranes. Most concerning is that he was overtly jaundiced with yellow staining of his sclera, mucous membranes, and skin. He had questionable abdominal pain and a cranial abdominal mass effect. We'll pause George's story for a moment and move to the specific topic of feline pancreatitis. Let's begin with a review of the anatomy. In the cat, we recognize 3 areas of the pancreas, right and left lobes and a central portion, similar to the dog. The organ is nestled within the proximal bend of the duodenum, which we know is the first segment of the small intestine. The pancreas is also closely associated with the pylorus and the greater curvature of the stomach, the liver, and the transverse colon, which you can imagine is sweeping across the bottom of the diagram here. An important difference from the canine pancreas is the fusion of the pancreatic duct and the common bile duct before entry into the major duodenal papilla, shown here. In dogs, the pancreatic duct and the common bile duct enter the major duodenal papilla separately, while the accessory pancreatic duct enters the minor duodenal papilla. We'll explore the implications of this unique anatomical feature of the cat later in the presentation. The pancreas subserves 2 major functions: exocrine secretion of digestive enzymes and endocrine secretion of hormones that regulate blood sugar. There are discrete functional areas for these tissues within the pancreas. The exocrine pancreas makes up most of the organ and includes all the secretory cells organized into acinni that produce the digestive enzymes. The proteolytic enzymes are secreted in inactive forms as zymogens, principally trypsinogen and chymotrypsinogen. Lipase, phospholipase, and esterase are enzymes that digest fats, while amylase and lactase digest complex carbohydrates. There are additional nucleolytic enzymes as well. Routinely measured amylase and lipase are secreted as active forms into the bloodstream. The islets of Langerhans are scattered about the parenchyma and are represented here by this colorful globe of cells. Oops, let me grab this arrow. It's not coming over. Here we go. So represented by this colorful globe of cells surrounded by acinar cells. These islet cells produce various hormones to regulate blood glucose, such as insulin, glucagon, proinsulin, amylin, C-peptide, somatostatin, and pancreatic polypeptide P. It's commonly agreed that the inciting event of pancreatitis in cats, dogs, and people is the activation of digestive enzymes within the pancreas. In health, there are a number of safeguards to reduce this risk. Likely you recall that the secretion of inactive enzymes or zymogens is one of the most important protective mechanisms. Secreted pancreatic zymogens are appropriately activated in the gut by enteropeptidases. We are using a diamond and darker color to represent activated enzymes in this area. Excuse me. Another safeguard is the internal segregation of zymogens from the lysosomal proteases that could activate them by these internal cytoplasmic membranes shown in this magnified area by this pink squiggly thing. Intracellular pH is typically maintained at levels less than 5. At pHs higher than 5, zymogens are more readily activated. Serine protease inhibitor cazole type 1, which we're representing or abbreviating as SPINK, shown here by the green granules, does inhibit trypsin, and SPINK1 is considered to be the first-line safeguard system that can inactivate about 20% of total trypsin activity if trypsinogen is accidentally converted to trypsin in acinar cells. We understand that mutations in the SPINK1 gene have been associated with chronic pancreatitis in other species. With all these protections in place, then how do zymogens, especially trypsinogen, get activated prematurely in pancreatic acinar cells? Some opportunities for premature activation include reflux of bile from the common bile duct. And that's a reflux that's made possible, again, by the fusion of these common bile ducts and pancreatic ducts. In feline patients with bacterial cholangitis or cholangiohepatitis, infected bile may reflux up the pancreatic duct or into the parenchyma, activating enzymes prematurely. You may imagine that reflux from the duodenum with intestinal contents or active enzymes and enterokinase activators could actually reach the pancreatic parenchyma and cause premature activation. We also understand that pancreatic duct obstruction can increase the likelihood of enzyme activation. I have represented a number of subcellular mechanisms for you on the right of this figure. We'll speak more about risk factors later, but most cases of pancreatitis are considered idiopathic or idiopathic. So activation of digestive enzymes, particularly trypsin, within the pancreas leads to autodigestion and disruption of pancreatic cell membranes. These are critical inciting events. However, the local and systemic inflammation that ensues is independent of trypsin activation, and instead it depends upon the ongoing stimulation of the nuclear factor kappa beta pathway, abbreviated NFKB, shown on the slide. Infiltration with leukocytes, particularly neutrophils, is a particularly important feature of this process and is in fact a target for new therapeutics such as Fuzaplidib that has conditional approval for the treatment of acute canine pancreatitis. Local and regional sequelae such as increased vascular permeability, pancreatic edema, and hemorrhage lead to pancreatic necrosis, and then we can anticipate peripancreatic fat necrosis. If these changes are severe, we recognize that the negative consequences can proceed like a chain of dominoes. The potential sequelae of acute pancreatitis are local at first with pancreatic necrosis that can regionalize if severe to include necrosis of the peripancreatic fat. These changes would certainly contribute to nonspecific gastrointestinal signs like poor appetite, vomiting, diarrhea, and possibly abdominal pain. Peritonitis with focal or generalized changes may ensue, and then we also understand that pleural effusion sometimes occurs. Blood glucose changes are common. With regional inflammation, we might see disrupted function of beta cells and disruption in insulin production. As time passes and severity increases with systemic effects, we may appreciate insulin resistance or even sepsis, altering blood glucose by consumption of glucose. Electrolyte changes may follow. With increasing severity of acute pancreatitis, there is a probability of acute organ injuries. We've listed here the lungs and the kidneys. We also can understand this may lead to sepsis or other life-threatening sequelae like thromboembolic disease, disseminated intravascular coagulopathy, systemic inflammatory response syndrome, and others. Chronic pancreatitis is a potential sequela, and we understand that diabetes and exocrine pancreatic insufficiency are more commonly seen in the wake of that chronic condition. So while in some patients an episode of acute pancreatitis may be assessed as chronic pancreatitis, as acute pancreatitis that then appears to resolve and apparently recurs, we can see repeated bouts of these acute inflammatory conditions becoming more chronic and associated with fibrosis. It is, however, theorized that chronic pancreatitis may arise independent of acute pancreatitis and trypsin activation. Effectors are included on this list, such as cholecystokinin and oxidative stressors, and it's thought that these features will activate pancreatic stellate cells, which is the source of the fibrosis, the hallmark of chronic pancreatitis. Most feline patients with pancreatitis do present with very nonspecific signs, like our cat George. Often they are lethargic or inappetent, losing weight, and sometimes vomiting. And sometimes they may display abdominal pain. There is considerable overlap between acute and chronic pancreatitis. In feline patients with pancreatitis, the laboratory findings of the minimum database are also highly variable and nonspecific. Patients may present with a non-regenerative anemia or hemoconcentration. We can see leukocytosis or leukopenia, and thrombocytopenia is not uncommon. Common biochemical abnormalities include increased liver enzymes, whether that's alanine transaminase or alkaline phosphatase, or both, increased total serum bilirubin that may be mild, moderate, or severe. We can see reductions in albumin and disruptions of cholesterol. GFR reductions associated with prerenal dehydration or hypoperfusion or renal injury can account for increased SDMA, BUN, and creatinine. We do understand that electrolyte changes will reflect a lot of things going on, including the cat's hydration status, food intake, and other factors. However, hypokalemia, hypochloremia, and hyponatremia comprise the most significant electrolyte changes, and along with hypocalcemia, in particular, ionized or total hypocalcemia, may be significant and warrant specific targeted supplementation and fluid choices. In contrast to dogs with pancreatitis, lipemia is relatively uncommon. When we look at the urinalysis, the urine quality is variable depending on the patient's hydration status and kidney function. Kidney injury markers such as proteinuria or tubular markers such as urine cystatin B may be increased in patients with pancreatitis and should not be ignored. Abdominal radiography is an important diagnostic test to rule out obstructive or other primary gastrointestinal diseases, but the changes are rarely specific and they cannot be used to definitively diagnose pancreatitis. However, common findings do include focal or generalized loss of serosal detail, increased angle between the pyloric antrum and the proximal duodenum, a mass effect in the right cranial quadrant, left gastric displacement, and right or ventrally displaced descending duodenum, or caudal displacement of the transverse colon. Ileus is reasonably common in patients with pancreatitis and can be shown radiographically, and occasionally will appreciate on the most cranial aspects of the abdominal films some pleural effusion in the thoracic cavity. This radiograph on the right is representing a focal loss of serosal detail, whereas we look at this single lateral radiograph here showing a generalized decrease in serosal detail. This whole cat radiograph, while not considered best practice, was helpful to diagnose pleural effusion. Inside the circled areas, you can recognize the increased opacity in the cranial thorax and some rounding of the lung lobes. And there are, on the VD radiograph, fissure lines encircled on the right. This feline patient also has biliary tract mineralization indicative of chronic biliary inflammation. Abdominal sonographic abnormalities vary, and the utility for diagnosing feline pancreatitis with this technique is considered to be dependent upon operator experience and technological sophistication, I guess. The sensitivity for this test has been estimated to be about 67%. We do list a few common ultrasonographic features here for you, including hyperechoic peripancreatic fat, peritoneal effusion, an increase in pancreatic thickness, irregular pancreatic margins, some change in echogenicity, which could be hyperechoic, hypoechoic, or mixed or mottled pancreas. The presence of pancreatic cysts, abscesses, and other nodular structures is consistent with pancreatitis. Less commonly, we would see a corrugated and or dilated duodenum or a dilated common bile or pancreatic duct. In the right, these ultrasound images are from a geriatric cat that's being treated for GI lymphoma and concurrent pancreatitis. Note the thickened appearance of the pancreas, its irregular contour, and the hyperechoic peripancreatic fat, all changes consistent with pancreatitis. The thickened gut wall in the lower image with loss of layering is consistent with feline chronic enteropathy, either inflammatory bowel disease or lymphoma. Excuse me. So, as we consider the differential diagnoses for cats with often vague and nonspecific illnesses, and that would be a sick cat that's hiding and not eating or drinking well, that might have nonspecific laboratory changes on the minimum database, increased kidney markers, hepatic enzyme increase, maybe some CBC changes. Pancreatitis is certainly one of our primary considerations. Other important differentials are cholangitis and cholangiohepatitis, feline chronic enteropathy, triaditis, which represents concurrent inflammation in the liver, gastrointestinal tract, and pancreas. So that's like cholangitis, inflammatory bowel disease, and pancreatitis. GI foreign bodies or other causes of obstruction are particularly important differentials, especially if vomiting is a major concern. Hepatic lipidosis is an important secondary condition that may contribute to the same clinical signs of poor appetite and even jaundice in patients with chronic or intermittent historical gastrointestinal signs. Peritonitis, be that sterile or associated with an infectious cause such as bacteria or FIP, is an important differential diagnosis for a sick cat that we've described. And certainly neoplasia should be on the list, perhaps higher in priority in your older patients. Of course, to complicate matters further, remember that we see most of these and many of these conditions concurrently in any combination. So ultimately, the diagnosis of pancreatitis is based on combining data, which is going to begin with your clinical acumen and your assessment of the history, the physical exam findings, and suggested findings on screening laboratory tests. Additional diagnostic tests are useful to increase your suspicion of pancreatitis, such as special assays and advanced imaging. Cytology of the pancreas or any effusions may be supportive. And while histopathology of pancreatic tissue is held to be the gold standard of diagnosis, the correlation between histopath changes and clinical findings is really not so clear. We do know that pancreatic lesions are also inconsistently distributed within the pancreas. In the absence of histopathology, a diagnosis of feline pancreatitis is based then on the presence of supportive clinical signs, consistent biochemistry findings, and ultrasonography findings, and the use of additional pancreas-specific clinical pathological tests. Expert resources have recommended testing patients suspected of having pancreatitis with feline lipase immunoreactivity tests, including the SPEC-FPL and SNAP-FPL, available through IDEXX and Texas A&M University. SNAP methodologies available for patient-side screening in real time. Other patient-side testing and development at IDEXX uses DGGR tests for lipase activity. Regrettably, amylase and lipase activities that are available on your general chemistry panels are really nonspecific, and those reflect enzymes from many sources, including the pancreas. B12 or folate testing is appropriate for patients with signs referable to abdominal disease, primarily to inform about the probability of chronic enteropathy as a differential diagnosis or comorbidity. Recall that B12 may be reduced when there is significant chronic small intestinal disease that interferes with reabsorption. Folate is reabsorbed in the proximal small intestine and may be reduced by malabsorption there or increased with small intestinal dysbiosis. TLI testing is sometimes helpful to diagnose pancreatitis, being increased in up to 30% of patients with feline pancreatitis. However, it is a rather nonspecific finding, and so its use is largely confined to confirming exocrine pancreatic insufficiency where the pancreas has lost exocrine function. TAP, or trypsinogen activation peptide, is a byproduct of trypsinogen activation that's normally excreted in the urine. It is, however, performance characteristics are inconsistent, and the lack of commercially available assay limits the utility of this analyte. Advanced imaging suffers from relative lack of availability, as well as increased costs and insufficient descriptive data studies. For your awareness, I'd like to point out that this reference interval for SPEC-FPL was extended about 1 year ago to reflect the results of a published validation study conducted by TAMU's GI laboratory. The upper limit of normal for SPEC-FPL was established at 4.4 micrograms per liter, and patient results between 4.5 and 8.7 would be considered increased or equivocal, with establishment of a clinical decision point of 8.8 micrograms per liter for pancreatitis. Thus, SPEC-FPL concentration greater than 8.8 micrograms per liter is consistent with pancreatitis. This cutoff target was created with a high expected specificity for excluding clinically healthy cats, specifically because while no single test is sufficient in diagnosing feline pancreatitis alone, it's believed that in practice it might be the only test or one of the only diagnostic tests used for this diagnosis. The adjustment in this feline SPEC lipase reference interval is considered to have no impact on interpretation, relevance, or reliability or sensitivity of the SNAP-FPL testing, and recommendations based on that test use do not change and have not changed. Validation and customer experience trials are underway for a new tool for your toolbox, the Catalyst Pancreatic Lipase Test. This point-of-care quantitative pancreatic lipase test has been specifically designed by IDEXX to align with the SPEC-FPL and CPL tests for diagnosis of acute and chronic pancreatitis and for patient monitoring. Please stay tuned for more information as this test becomes available in late 2024. As I stated earlier, pancreatic histopathology has been described as the gold standard for the diagnosis of pancreatitis and for discrimination between acute and chronic conditions. However, this test is not routinely available to clinicians in antemortem cases. Current studies evaluating the accuracy of less invasive testing methods rarely compare to this gold standard as a source of truth because fewer results are available. When biopsy is elected as a part of an exploratory laparotomy, selection of a representative site or sites may be challenging, as lesions may be focally or multifocally distributed. Further, as we said earlier, there's been no clear correlation between the number of sites affected and the lesion severity with patient performance, clinical signs, and outcome. If biopsy is elected, multiple specimens are suggested, And if only one specimen is permitted or chosen, the left limb has been recommended by some authors based on prevalence of lesions in necropsy studies. Histopathological lesions consistent with acute pancreatitis include suppurative inflammation, edema, fat necrosis, hemorrhage, and thrombi. On the other hand, chronic pancreatitis is characterized by lymphocytic infiltration with fibrosis, acinar atrophy, cystic degeneration, and in some cases, even lack of inflammatory cells. And while cytologic aspirates of the pancreas are generally safely acquired, samples from an acutely inflamed pancreas are more likely to be cellular than from chronically inflamed ones. Epithelial cells may be highly dysplastic and difficult to distinguish from neoplasia in the case of acute pancreatitis. And with chronic pancreatitis, we know that highly lymphocytic aspirates might represent lymphoid neoplasia instead of inflammation. And while neoplasia is less common than inflammatory disease, these are diagnoses that can't be established with cytologic aspirates with confidence. In either case, lack of inflammation on aspiration cytology cannot be used to rule out pancreatitis. Thus, we consider aspiration cytology supportive information. Effusions are more common in the peripancreatic area of patients with acute pancreatitis and sometimes occur in the pleural space. They have varying degrees of protein and cellularity and may be characterized as an exudate or a modified transidate. Bacteria are not often observed, and most aspirates are negative when cultured for microbial growth. This representative sample of peritoneal effusion from a patient with pancreatitis was moderately cellular with degenerative neutrophils and some large macrophages that appear to contain foamy debris that could represent fat. And then we see some blue changes that represent hemosiderin accumulation inside the macrophages. The total protein was 3.5 grams per deciliter, and the fluid was assessed as inflammatory, consistent with a high protein transidate based on nucleated cell count of less than 5,000 per microliter. There were a few red blood cells that you can see in the periphery. Grossly, this fluid would likely have been colorless and clear. As we look at exudates, we could expect the samples to be more turbid or flocculent in character, or they might be discolored with bile in a patient with icterus or jaundice. These pancreatic biopsies represent acute inflammations with suppurative. These pancreatic biopsies represent acute changes with suppurative inflammation on the left. Many neutrophils are apparent in the interstitium and also within the pancreatic lobule in the lower right, and these are represented by the yellow arrowheads. In the sample on the right, please note the lymphoplasmacytic infiltrate with severe interstitial fibrosis that is typical of chronic pancreatitis. Fibrosis is also replacing functional lobular tissue. It's perhaps easy to understand how a fine needle aspirate of either one of these tissues could miss the inflammatory cell component and be completely non-contributory. As we think about the clinical presentation of cats with pancreatitis and the attendant findings, let's remember again that most patients with acute or chronic pancreatitis have vague and nonspecific signs that include lethargy and anorexia or hyporexia. Vomiting is actually reported in only about 52% or half the patients. Feline patients with acute pancreatitis typically have peracute onset of signs. They may have abdominal pain, but this is considered unreliable and was reported in less than 1/3 of cats studied. More obvious changes on abdominal ultrasound may be present in acute pancreatitis, and we might have more consistently increased FPL with higher magnitudes. More severe complications are typically associated with acute pancreatitis, and as we've seen earlier, the cytology and histopathology are typically supportive of suppurative or neutrophilic inflammation. The clinical course is typically recovery or death. Whereas with chronic pancreatitis, there is a chronic or insidious history. They may have no obvious abdominal discomfort. In fact, that's pretty common in my experience. They may have inconsistent changes on their ultrasound and possibly less dramatically or inconsistently increased FPL or specific pancreatic lipase. Typically, they have more obvious impact of concurrent disease or more obvious incidence of a concurrent disease. as seen previously, the cytology and histopathology would show lymphoplasmacytic inflammation and fibrosis. And again, the signs would typically be chronic or intermittent. Clinically, there may be instances of severe signs that represent flare-ups of acute pancreatitis in a patient who seems to have a more chronic course. So if we think about risk factors, there are several recognized risk factors listed here. Viral and parasitic infection of the pancreas may contribute to pancreatic inflammation or diseases like toxoplasmosis, as may trauma, including surgery, which we now might attribute even to the anesthesia and related changes such as hypotension. Earlier, we covered the impact of biliary disease or GI disease with reflux contributing to premature trypsin activation within the pancreas. Again, that's theorized to be the primary event leading to acute pancreatitis anyway. Cancer and drug exposures appear to be less common causes of pancreatitis in cats. Azathioprine, phenobarbital, and potassium bromide, medications that are known to be pancreas provocative in dogs, are not as commonly used in cats and are not recognized risk in the species. Also, in contrast to dogs, obesity and fatty diets are not recognized risk factors for cats. Like canine pancreatitis, then, most cases of feline pancreatitis appear to be spontaneous or idiopathic without a recognized cause that we can address or treat. These potential complications and sequelae were discussed earlier, just reiterating here that there are many troublesome complications and conditions that may exacerbate acute and chronic pancreatitis, with the systemic manifestations on the right being more typically associated with acute pancreatitis. Comorbidities or concurrent diseases that occur commonly with pancreatitis may also be differential diagnoses for sick cats that are presented with non-specific gastrointestinal signs or even overt jaundice. It's not clear that they are causative. Sometimes they may be a consequence or just related findings. We saw this list earlier where cholangiohepatitis and cholangitis, inflammatory bowel disease, were commonly grouped with pancreatitis as sort of triaditis. And these inflammatory conditions can exist singly or in any combination. Patients with cholestasis due to biliary obstructive disease or intrahepatic cholestasis associated with lipidosis are commonly found in patients with pancreatitis. We also know that diabetes mellitus from absolute or relative insulin deficiency has clearly been associated with feline pancreatitis. Older cats in particular often have chronic kidney disease, although this has not been identified as a risk factor or cause for pancreatitis. So, how to address feline pancreatitis and help these cats feel and do better? Upon diagnosing pancreatitis, we'd really like to treat or eliminate any of the recognized risk factors. However, since idiopathic disease is most common, our approach is regrettably limited to supportive care, with the magnitude being determined by the patient's clinical status and other findings. These concepts are valid for both acute and chronic pancreatitis treatment, and we will emphasize specific indication and treatment as we progress through this course. Fluid therapy is the cornerstone for patients with acute pancreatitis since dehydration is quite common and hypotension is a possibility. Fluids may be indicated for some patients with chronic pancreatitis who are marginally hydrated or having concurrent illness limiting their intake of food and water. We should always attend to symptoms and signs and attend, importantly, to nutrition. And it will be important to prevent and treat complications and comorbidities. I'm and many of my colleagues are big believers in the value of TLC, which is tender loving care, right? To reduce stress, fear, and anxiety. The patient's needs will guide this experience, and so we'll have to look at the patient whether they want more or less touch. For instance, this little orange cat clearly likes having high touch to take care of him. The goals of fluid treatment with crystalloids are to restore and maintain normal volemia, and rehydrate the patient. So that means replacing the lost free water. Fluid therapy is indicated for most patients with acute pancreatitis and often for patients with chronic pancreatitis who are presented for clinical signs or worsening condition. Establishing normal volume is expected to assist with pancreatic perfusion and the perfusion of other organs, and to prevent microthrombi and other deleterious events. Crystalloids, such as lactated ringers or acetated ringers, are often advised to aid with restoring electrolyte balance and addressing any acid-base imbalance or metabolic acidosis. Close monitoring is needed to avoid overhydration. We know that the endothelial glycocalyx lining of blood vessels is remarkably sensitive or susceptible to injury by overly zealous or liberal fluid administration, and that can ultimately result in substantial progression of illness in edema and increased vascular leakiness, amongst other things. Advanced fluid therapy is typically reserved for patients with moderate to severe acute pancreatitis, and that represents opportunities to increase the colloidal osmotic pressure, promoting organ perfusion without substantial fluid overload. These products are used in patients that are intolerant of fluid volume or are hypotensive and refractory to crystalloid treatment. Excuse me, I need to go back. The blood products that I've listed here are primarily indicated for patients with coagulopathy. There's really been no clear data showing survival benefit of plasma in dogs or people receiving plasma for treatment of acute pancreatitis. There are no studies in cats that support this position. We do know that colloids and recognize that they can contribute to coagulopathy and acute renal injury, so they should always be used with discretion and care. So I do think that part of our progress with managing feline pancreatitis is the combined effort of experts who have recently published a consensus statement on pancreatitis in cats after critically reviewing the available literature and sharing their collective experiences. This is an open access publication, free for all to download and read, in the Journal of Veterinary Internal Medicine in 2021. In addition to many of the concepts shared in this publication, this team has also prepared supplemental information, tables guiding specific fluid treatment and drug doses. So you'll want to scroll all the way to the end of the publication to find those supplemental resources. This group has actually summarized the evidence for aggressive pain management for feline patients with both acute and chronic pancreatitis, believing abdominal pain to be quite underestimated in cats. They recommend the use of opioids and meropitate citrate, we know as Cerenia, which has visceral analgesic properties. These products can be useful in home and hospital environments. Antiemetic drugs and anti-nausea drugs, such as meropitate again and ondansetron, and prokinetics may be combined to treat refractory vomiting and assist with tolerance of oral nutrition strategies. For hospitalized patients with poor gastric emptying or ileus, we might look at a metoclopramide continuous rate infusion. Compounded cisapride, which may be difficult to source, can be prescribed to aid with gastric motility in these patients, in addition to its more common use for megacolon. We've gratefully recognized improvements in access to appetite stimulants. I think these are noteworthy. Mirtazapine is now available as an FDA-approved product as a transdermal form, Mirataz. These are safe and effective treatments for inappetence to promote voluntary food intake in acute or chronic pancreatitis. Capmorelin has been approved for cats with poor appetite associated with chronic kidney disease, and it sometimes has been used off-label in cats with pancreatitis. The conversations about steroids and immunosuppressives are a little bit more complicated. It really depends on, for acute pancreatitis, whether or not a immune-mediated component or concurrent disease is recognized or suspected, such as inflammatory bowel disease or sterile cholangiohepatitis. Currently, there is no proven or published evidence that use of a corticosteroid for its broad anti-inflammatory effect has improved the outcome for cats with acute pancreatitis. This expert panel was divided on the application of steroids at anti-inflammatory or immunosuppressive doses for the treatment of chronic pancreatitis, which is, we know, due to these lymphocytic inflammatory changes and fibrosis. Risks of using corticosteroids include increasing insulin resistance and maybe the onset of type 2 diabetes. Immunosuppressives like cyclosporin can be used long-term in the cat, but we need to be mindful of the possibility of toxoplasmosis as a recrudescent phenomenon in that subset of patients. The list of symptomatic treatments for feline pancreatitis that might help some patients is extensive. These working authors have found no evidence of efficacy for pancreatitis as a solitary condition. Examination of the possible role in addressing or treating comorbidities is really beyond the scope of this presentation. We think that generally many of these treatments are unlikely to cause harm, although we all understand that giving cats lots of different medications presents its own unique challenge. I would like to address two in some detail, and that's the use of antibiotics and dopamine as a continuous rate infusion. Antibiotic treatment was rationally offered to cats with pancreatitis for a while based on a 2013 study published by Dr. Tweet et al., where he found bacteria by advanced molecular diagnostics in 35% of cats with moderate to severe pancreatitis. So pretty small group. That was 11 of 31 cats reported. And these bacteria were surmised to be there by virtue of bacterial translocation from the GI tract. This consensus panel has questioned the clinical relevance of these findings, and they do not recommend antibiotics for most cats with pancreatitis unless there are other indications. We as veterinarians are a very important steward of antibiotic use in our patients, and that is really essential that we assume this responsibility due to the increasing worldwide health risks of increasing antimicrobial resistance. And on an individual patient level, we have the potential for adversity, including GI intolerance or some disruption of the intestinal microbiome when antibiotics are used. And I would suggest to avoid the temptation to use antibiotics in acute or chronic feline pancreatitis. The dopamine CRI or other vasopressor agents may be appropriately used or indicated for treatment of refractory hypotension that hasn't gotten better with colloids or aggressive crystalloid treatment. There is a transient positive effect on pancreatic blood flow when patients receive dopamine continuous rate infusion and some reduction in micropermeability of that organ. However, these authors believe that the limited benefit offered isn't really worth the risk of vomiting that happens with dopamine CRI, and certainly not worth the additional cost of care. An area where I do think veterinarians have made meaningful progress individually is in treating cats with pancreatitis and rapidly recognizing their need for aggressive nutritional support. Many clinicians understand that force feeding is problematic since it can exacerbate nausea and promote food aversions. One should not leave food in front of a nauseated cat. Nasogastric tubes can be placed with local anesthesia with none to minimal sedation. Esophagostomy tubes do require general anesthesia, and both of these tubes are suitable for feeding liquid diets. Gastrostomy tubes should be considered if endoscopy or surgery is planned and or a long-term feeding course or strategy is anticipated. Adopting the mantra of if the gut works, use it, we suggest the enteral route, whenever possible, be utilized and that parenteral nutrition only be considered if enteral nutrition is not being tolerated. Some benefits of enteral nutrition tube strategies are summarized here. In my opinion, these are well tolerated by most cats and cat owners. It is important to report to owners, however, that there are complications that can arise. Up to 44% of patients in one study of esophagostomy tubes. Fortunately, most of these complications are not serious. Feeding tubes can help ensure proper caloric intake. They can give us access to provide enteral fluids or water. Feeding tubes can help bypass the mouth and the taste and avoid development of a food aversion or reaction maybe to a noxious medication. A bonus would be in the use of larger feeding tubes. Those can actually facilitate administration of medications. This little kitty on the right looks like it has a gastrostomy tube placed in. One can easily use crushed medications or blenderized food for longer term maintenance. The smaller nasoesophageal tubes are 5 or 8 French only, very small diameter, and we don't want to risk clogging them with anything really other than a fluid or a suspension that's commercially prepared. There really is, despite this slide title, there really is no single ideal diet for feline pancreatitis, and there's limited evidence available to guide us in this area. Often nutrient composition and nutrient density are guided by the nutritional needs of concurrent diseases that the patient may have or prior dietary needs. The working nutritional assessment was always going to begin with a comprehensive patient assessment, body and muscle conditions, scoring, and detailed diet history of how and what the pet has eaten successfully and what they've been eating recently. There is, however, at this time, no compelling evidence that cats with pancreatitis need fat restriction, which is in contrast to dogs. Another interesting difference between the two species is that the primary stimulus for pancreatic secretion in cats is intact protein molecules, whereas in dog, we consider it to be protein breakdown products and consider them to be more stimulatory of the pancreas. For cats, then, with pancreatitis, a hydrolyzed protein diet might be a reasonable choice for a maintenance diet. In the acute hospital setting, attempting to feed a highly digestible and palatable diet by mouth is a reasonable first choice. Should the cat refuse this diet or appear to develop a food aversion, then the targeted hydrolyzed protein diet that we might need for maintenance treatment could still be an option. For the anorectic or hyperexic cat, which is really any cat with pancreatitis, we want to calculate a resting energy requirement using one of these two formulae that I've provided here for you, and then begin with a conservative percentage of feeding, so 25 to 50% of that resting energy requirement. Dr. Cridge and coworkers have suggested that stable patients should receive 3 to 5 days to meet their energy needs, and if you cannot achieve that, then they need assisted enteral nutrition via a feeding tube. A continuous rate infusion can be helpful in those patients that don't tolerate bolus feeding, despite use of anti-nausea and prokinetic medications. I'll refer you to Dr. Cridge's recent open access paper in the Journal of the American Veterinary Medical Association for a detailed discussion of nutritional management of pancreatitis concurrent with diabetes mellitus, chronic enteropathy, or CKD, and the nutrient composition of a variety of commercial diets and liquid products. As we referenced earlier in this talk, there are many potential complications to prevent when possible and treat when recognized. Excellent fluid and nutrition management is a clear priority for clinicians caring for cats with pancreatitis. Monitoring patients for the onset of complications with appropriate testing is also of paramount importance. Successful outcomes for these sick cats also depend on managing their concurrent diseases, and there are 3 common conditions listed here that we'll touch on. Patients with chronic enteropathy, assessed as inflammatory bowel disease, may have differing dietary requirements and frequently will require immunosuppressive medications such as prednisolone or chlorambucil, and they will typically also require cobalamin supplementation. Most patients with cholangiohepatitis will not need a special diet unless they have liver dysfunction associated with their disease. Liver protectants such as S-adenosylmethionine, vitamin E, and ursodiol are often prescribed. Guided by biopsy and culture testing or results, clinicians may prescribe immunosuppressive medications or antibiotics for more specific treatment of cholangiohepatitis. Patients with concurrent diabetes are often managed with regular insulin while they're sick and ketotic, transitioning to longer-acting products for maintenance. The new class of SGLT2 inhibitors carry manufacturer recommendations that they are contraindicated in cats with pancreatitis and that they should be reserved for uncomplicated type 2 diabetics. And they really should only be administered to newly diagnosed diabetic cats that are not clinically ill from their diabetes or another disease. Whether there might be a utility for patients after resolution of acute pancreatitis or extra label use in cats with stable chronic pancreatitis has not been well studied, so we cannot recommend that at this time. Please consult with the drug manufacturer for more detailed information about these products. For cats with concurrent pancreatitis and diabetes mellitus, feeding a lower carbohydrate limited ingredient diet should be considered. If the clinical signs of pancreatitis are really minimal, then there may be less priority given to the limited ingredient diet choices. Helping patients achieve a healthy weight and body condition should be a long-term goal, and close monitoring of weight and glycemic control emphasized and communicated clearly to pet owners. I'll refer you again to Dr. Cridge's excellent review in JAVMA of the nutritional management of pancreatitis and concurrent diseases in dogs and cats for more information. People view their pets as family members, even royalty, and we need to respect and support this very important relationship, the human-animal bond. Pet owners are usually highly motivated to do what they can to help their pets. And as veterinarians, we can offer guidance about the available spectrum of care, what evidence-based practices are reasonable for this patient at this time. The frequency and type of follow-up of feline pancreatitis is going to depend on the patient's status. We'll continue to emphasize the importance of pet owner history and observations, physical findings, and laboratory trends. And of course, this list of suggested laboratory tests is by no means exhaustive, and other diagnostic tests may be needed in particular patients. We'll look at a PCV in total solids or a CBC to assess the hemogram, and a chemistry with electrolytes routinely. Urinalyses will help us assess for ketonuria, secondary bacterial infection, and understand current kidney function. I do want to encourage you to please continue to monitor with the same pancreatic lipase testing that you established as your baseline during the diagnosis of the illness. For now, we recommend the SPEC-FPL. In late 2024, the Catalyst pancreatic lipase should also be available for patient-side diagnostic testing and monitoring. Cobalamin monitoring is commonly needed for patients with a significant GI disease, triaditis, or exocrine pancreatic insufficiency that are receiving cobalamin supplementation. Sonography can be used as patients are improving, or if they are not improving, to look for complications or new conditions. So cats with mild to moderate acute pancreatitis generally have a pretty good prognosis with appropriate management. Whereas cats with severe acute pancreatitis, and that's especially when there are complications or comorbidities, have a guarded to grave prognosis. According to the Feline Pancreatitis Consensus Statement, the mortality rate in cats with acute pancreatitis ranges from 9% to 41% based on 4 studies. Low plasma ionized calcium concentrations have been associated with poor outcomes. In cats with acute pancreatitis, hypoglycemia and azotemia are also poor prognostic indicators. Pleural effusion, hepatic lipidosis, separative pancreatitis, leukopenia, and hyperkalemia have all been reported as indicators of poor prognosis, but those findings were not supported by this group's review. Patients with chronic pancreatitis may do well for some time, realizing that this is a chronic, likely irreversible condition. We understand that signs may wax and wane. The prognoses for patients with complications such as diabetes mellitus or exocrine pancreatic insufficiency are not necessarily worse, but the level of care and specific treatment needed is substantially increased and expected to be lifelong. Remember George, our teaching case? His story could be similar to your next patient with pancreatitis. When we left George, he was being admitted as a 6-7-year-old cat with dehydration, jaundice, and a suspected abdominal pain with a cranial abdominal mass effect. We can generate a list of important differentials for George that begin with a focus on the jaundice and the abdominal exam findings. In this case, then, hepatobiliary disease seems more likely than hemolytic disease as a cause of the jaundice. And certainly the mass effect could be arising from any organ, including the liver, gallbladder, stomach, or pancreas, amongst others. The initial minimum database should include a CBC, a biochemistry panel with electrolytes and urinalysis, and a specialty test for feline pancreatitis. And likely this patient would need advanced imaging with a plan for abdominal ultrasound. Many clinicians would recommend chest radiographs to assess for metastasis of cancer or as a pre-anesthetic screen if anesthesia or surgery were planned. Coagulation testing is often recommended for patients with jaundice, since hepatic or post-hepatic disease can contribute to vitamin K responsive bleeding tendency, or we may observe DIC. If aspiration cytology or feeding tubes are on the horizon, then coagulation testing is strongly encouraged. As we look together at these VetConnect Plus results, I'll point out that results outside the IDEXX reference interval appear in red, and the speed bars can help you understand the magnitude of change. Assessing George's CBC, we find no evidence of anemia or reticulocytosis. He had a mild neutrophilia with lymphopenia and mild monocytosis, which could be consistent with inflammation, stress, or the combination. We do think that monocytosis in cats is more commonly associated with inflammation rather than stress. The slide review supported the reported differential with no evidence of a left shift or toxicity. In general, this was not too bad overall. However, when we evaluate quickly the chemistry screen, we have lots of red and lots of warning signs. These are more remarkable. So this is just a sort of view that's hard to see. So let's go ahead and examine things a little more closely. There was modest hyperglycemia, indicators of kidney impact with increased SDMA, supporting a reduction in GFR, and an increased urinary cystatin B, indicating active kidney injury at the level of the renal tubule. He had mild hypokalemia and hypochloremia with normal sodium and calcium concentrations. Alkaline phosphatase was increased with normal ALT and GGT, supporting cholestasis, which was consistent with a total bilirubin of 12.8, rather surprising for the moderate jaundice assessed on his physical exam. The specific pancreatic lipase was 50 micrograms per deciliter, 50 micrograms per liter, which is the upper limit of the dynamic range for pancreatic lipase. The magnitude of this result and the attendant biochemistry changes are consistent with pancreatitis as a primary or secondary disease and concurrent hepatobiliary disease, either primary or secondary. Fasting hypercholesterolemia was noted here, which is an uncommon finding in cats. So the urine was pretty messy. We have a brown color reported. In patients with suspected or possible coagulopathy, a free catch urine might actually be preferred over cystocentesis to avoid causing bleeding from a cystocentesis. The cat's urine-specific gravity was reported as 1021, and that is inappropriate. We do expect cats to be able to concentrate to greater than or equal to 1035 for specific gravity. However, the presence of 3+ glucothiuria and those osmotically active particles does complicate this assessment. You can see that urine protein and ketones were not able to be determined in the face of the pigmenturia and 3+ bilirubinuria. The cellular casts, let me drag this over here, please call your attention. Well, okay. I have the cellular casts at the bottom of the report would be further indication of the possibility of ongoing renal tubular injury. Some selective imaging results include chest radiographs and abdominal ultrasound. On the chest rads, George had a small caudal vena cava, and there was a mild decrease in lung vascularity noted. These changes are consistent with dehydration, shock, or could be hypoadrenocorticism. In George's case, myocardial failure, restrictive pericarditis, or right to left shunt was considered less likely. Technique with increased penetration of the radiographs can diminish or obscure lung vascularity if they are overexposed. That would not, however, account for a small caudal vena cava. When we look at the results of the abdominal ultrasound, his kidneys were reported to be bilaterally symmetric and within normal limits. The liver was diffusely enlarged, homogeneous, and slightly hyperechoic. The gallbladder was distended with some sludge and possibly some small cololiths. Common bile duct was measured at the upper limit of normal, which we know is about 4 millimeters. The cat's pancreas was enlarged. There was increased echogenicity of the peripancreatic fat and scant bit of effusion in the peripancreatic area. His intestinal loops were fluid-filled proximally, diffusely thickened, and there was preservation of the laminar pattern. So as we assess George's physical status and all the lab work and all the findings and prepare for treatment, realize that we have a very robust list of problems and it's long complicated. This is a very sick cat. He has dehydration, he has hyporexia and weight loss, he's jaundiced, he has abdominal pain, hyperglycemia, inappropriately concentrated urine, evidence of kidney injury. He's been inadequately nourished for some time, and he has a long-standing history of chronic intermittent GI signs. And then we have sonographic changes in multiple organs. So evidence that would suggest pancreatitis, some sort of primary liver disease like cholangitis or cholecystitis, or maybe a secondary condition like hepatic lipidosis. And he has gastrointestinal changes that likely support chronic enteropathy. So in planning his treatment, we want to remember our cornerstones of treatment, and definitely a sick cat like this needs fluid restoration and volume attention immediately. So that's going to be aggressive IV fluid therapy, maybe offering oral fluids if he seems tolerant of those. We would reserve something like subcutaneous fluids, of course, for an outpatient situation or a patient who wasn't so ill. The particular medications that we are going to want to use to deal with his nausea and maybe sporadic vomiting are going to probably include meropitant, which we know is Serenia, or ondansetron. And those can be combined with a metoclopramide CRI if we think ileus is an outstanding concern. Appetite stimulants like Myrtaz and capromorelin could be rationally used in this situation. As we think about his liver changes, I would certainly not use antibiotics in this patient myself, and I would not have preferred this for most patients with liver disease in this setting. We do have the option of using ursodiol, a synthetic bile acid, but that can be relatively contraindicated in patients with common bile duct obstruction and or patients that maybe have recently had that resolved. We might avoid using a product like that. George has demonstrated abdominal pain pretty convincingly and is a cat, so we know that he needs some pain relief here. We know that opioids and ketamine are pretty successful in this area and can be used with a lidocaine CRI if necessary. Insulin would be guided by ongoing blood sugar measurements. Vitamin K1, if we can't measure that, then we can typically administer that safely. So pending the results of a coagulation study, if that's not available patient side, we could consider using a vitamin K1 supplement to help us move ahead with any invasive interventions that we need to put in, like a feeding tube. We've got cobalamin, again, as a supplement that can be administered safely without a baseline cobalamin level. It's a water-soluble vitamin. And if there's no money for cobalamin testing, then I would certainly administer that in this patient, like George. George, we would typically recommend an E-tube and use or an esophagostomy tube and recommend an adjustable diet. For the question about steroids, I think we would defer that until he has demonstrated some clear need for other anti-inflammatories or immunomodulatory drugs. So how might things have gone for George, right? Exactly, George. So we're assessing him to be a cat with probable triaditis and maybe possibly secondary hepatic lipidosis. We know that in the face of fluid therapy, he was successfully stabilized over 24 to 48 hours with correction of his hyperglycemia and dehydration. His electrolytes were improved, and we were able to see normalization of SDMA and resolution of the increased urinary cystatin B. So we consider this to be sort of slow improvement, certainly steady at this point to stabilization. He was stable enough to have an esophagostomy tube placed on the second day. And we've mentioned already a highly digestible diet was our first choice for George. The kitty wasn't making the kind of improvement that we'd hoped for in clinical signs, kind of slowly moving toward better. And that's with just sort of general demeanor and interest in food, even though he was being tube feedings placed. We can see cats who do really well start eating even with a feeding tube. So a decision was made at around day 5 or 6 to go ahead and add some corticosteroids. Now, In this setting, prior to adding corticosteroids, if we have a physiologically stable cat and a cat who's got no evidence of coagulopathy, and we think maybe a reasonable anesthetic candidate, this is an appropriate time to revisit really full diagnostics, right? We can offer him endoscopy, maybe a percutaneous liver biopsy or aspiration cytology. And so these are opportunities to get more information about his condition and understand whether his concurrent diseases or comorbidities are going to justify the administration of corticosteroids, which does carry a risk with it of increasing the risk of diabetes and insulin resistance, and maybe can make recovery from hepatic lipidosis a little bit more complicated or delayed. However, the decision was made to give this cat some moderate doses of corticosteroids around day 5 or 6. Interestingly enough, he seemed to improve substantially, as did his jaundice. So we were seeing the liver enzymes getting slowly better, but a lot better after corticosteroids were administered. Happy news is that he was doing a lot better clinically. And so at the end of week 2, the feeding tube could be removed and his steroids were discontinued or weaned off. But in the face of this steroid taper, the mild GI signs started to recur, right? We started to see a little bit of sporadic vomiting. I can't recall if there was diarrhea. And the liver enzymes started to creep up again. So steroids were restarted, and chlorambucil was actually added for a chronic maintenance regimen for this cat for long-term treatment of triaditis. His FPL had improved at the end of 2 weeks, but it wasn't better. I mean, he started out at 50, right? And the ultrasound here showed some questionable improvement around the 2 or 3 week recheck, but this was not considered the main factor to determine his clinical course, because he was doing well clinically and gaining weight. So again, a complicated case with a happy ending because of very aggressive and judicious intervention by his clinicians. So, with feline pancreatitis, are we any better? While the diagnosis of pancreatitis remains a challenge, we are better because we have increased access to validated and accurate diagnostic tests for feline pancreatitis. We have a heightened awareness of the condition and a willingness to be more proactive at diagnosis and treatment, particularly nutritional support. We have more helpful aids to remind us to perform appropriate tests, GI panels and vomiting cat panels. And we also have a very engaged research community that's creating and curating evidence for existing tests and management tools. So I'll leave you with a simple take-home point here, which everybody likes to say, is that cats are not small dogs. So as you've seen, feline pancreatitis has some similarities to canine pancreatitis, but it's really quite different in the sort of chronic insidious course that it often takes, and finding abdominal pain evidence and vomiting are not consistently helpful in cats with pancreatitis, and we really can't exclude that diagnosis if those things are missing. In summary, I'll leave you with this. The diagnosis of pancreatitis is based on a combination of a clinical picture, laboratory results, and a level of suspicion or intuition. It is true that complications and comorbidities are common, and serious sequelae are possible. There's no specific treatment for feline pancreatitis. We do need to tailor treatment to the patient's clinical evaluation, their problems, and their response to treatment. Nutrition is a very important part of therapy. Low-fat diets may not be needed for cats, and we'll need to look at the whole picture before choosing a diet for a patient with pancreatitis. Prognosis is generally good with aggressive treatment. The exception would be a patient with severe acute pancreatitis, particularly if they are hypocalcemic or have signs of sepsis. Thank you for viewing this presentation. I'd like to thank also Dr. Nancy Sanders, my colleague and IDEXX Medical Education Specialist, for her contributions to this course and her critical perspective on feline pancreatitis.